Aibowan, and a very good evening to all our viewers here on TV1. I'm Dr. Dilshan Fernando, and this is your weekly dose of wellness here on Healthline. And I would like to also extend a warm welcome to all our viewers joining in across the globe via YouTube. So today we are going to be talking about a gland exclusive to males, but doesn't matter even if you're a female, because it will be a very important topic for you to know, for you to advise your male family members, your fathers, brothers, maybe your husbands. Today we are going to be talking about the prostate gland and the problems that occur in this gland. This will be very important, especially for the elderly males in your families. And to talk about this matter, we have invited one of the biggest names in urological surgery in Sri Lanka. It is a great honor and privilege to welcome back to the Healthline studios Professor Neville Perera. A very good evening to you, sir, and thank you very much for gracing the Healthline studios again.
Good evening, Dilshan, and wish you a happy new year.
Thank
you for inviting me.
So, first and foremost, sir, before we go into the problems of the prostate gland, I think it would be pertinent to discuss what this prostate gland is and what is its role in the males.
Yes, as you have already mentioned, prostate gland is a gland which is situated in the male genital system inside the body and just below the bladder, which is actually found in all males. And when you are young, its function is that to secrete certain secretions into the seminal fluids so that the sperms can get nourished with that. So people with rare diseases of maldevelopment of this prostate gland, they are subfertile because their semen quality is not good. So when you are young, that is the main function of the prostate gland, to contribute to the seminal fluid to a certain extent.
So before we move on further with our discussion, sir, if you can just give a brief elaboration of the anatomy of this prostate. I'm sure our viewers would see these diagrams that we show on the screen as we move along, but if you can just give us a explanation of the anatomy so that they might be able to understand better what these symptoms and signs and how these problems in the prostate cause these symptoms and signs.
Yes. Prostate gland, as I was mentioning earlier, it is situated, it surrounds the water pipe, that is the tube which brings urine out from the bladder, and the water pipe travels through this gland. So when this gland get enlarged or it get involved in disease, the first thing which will happen is the water pipe getting blocked. So when the urethra or the water pipe get blocked, then you start getting symptoms. So as time goes on, this gland can become enlarged in size. So it will block the water pipe. So this anatomical position of the gland which will give rise to all the symptoms.
Exactly. When we talk about symptoms, we've heard in our day-to-day practice about these lower urinary tract symptoms associated with the enlargement of the prostate. So if you can just elaborate what these symptoms are, if indeed one of our viewers are experiencing these symptoms, I'm sure they can relate to what we are talking about, and they may be encouraged to seek medical attention because they might be worrying what these symptoms are about.
Yes, as I was mentioning earlier, when the gland enlarges, it can enlarge from inside to outside, or it can get enlarged into the water pipe. So what happens in most occasions, this gland grows into the water pipe, so that the earliest symptom will be the blockage of the urinary stream. So the symptoms will begin there, and first thing you will experience will be difficulty in passing urine. When you pass urine, as you know, when you get the urge to pass urine, if the circumstances are good, you just pass urine with a good flow. But as you grow old, when the prostate gland is blocking your water pipe, you suddenly find that you can't start the urine stream whenever you want. So you have to sometimes wait for a while, and there's a word for that, that is called hesitancy. You have to hesitate for a while, wait for say half a minute or so to start the stream. That will be a kind of a difficult and different experience for men. And when you start the urine stream also, that may be an intermittent stream. You pass a little bit and then suddenly it stops, and then again it will start again. So stopping and starting. And apart from that, the stream itself will be quite poor, because as you know, you should be able to, when you stand and void, stream should straight away go to the commode. But person with prostate obstruction or block, you will find that it is dropping onto your feet, and that can be quite embarrassing. And also another symptom will be that the urgency, what we call the urgency, where you will want to pass urine, and all of us, we get some sensation when the bladder is full, but if the circumstances are not good, we will be able to hold on till for maybe for another half an hour, 1 hour, till we get a good place to pass urine. But the urgency is due to the irritation of the bladder by this prostate gland. So whenever you want to pass urine, you have to run to the toilet. Otherwise you feel as if you are going to just empty your bladder without your knowledge. So that can happen, and that is called urge incontinence. And also, because you are not emptying your bladder fully, you always feel that after passing urine, there's some amount of urine is left in your bladder. A normal person, once he has emptied the bladder, you should feel for another 3-4 hours, you should feel free of that sensation. But the people with prostate will always feel after passing urine that there's a little bit of urine is still left there. So with that feeling, if there is a lot of urine there inside the bladder, you have to pass urine very frequently. A normal person will be passing urine, if you drink a normal amount of water, that's about 2 liters or 2.5 liters a day, a person should be passing urine about 4 to 5 times a day. That is a natural frequency. But these people with this prostate irritation and prostate block, they will be passing urine about 10-15 times a day, because they can't empty their bladder properly. And also the first thing is, as we have been mentioning, what affects the wife is that getting up in the night. That is, the scientific term is Nocturia. That is getting up in the night, because the bladder is not emptying and bladder is irritated by this prostate gland. You don't get a peaceful sleep. Sometimes 3-4 times a night you have to get up and go to the toilet, and that is where the spouse get involved. But her sleep also will get disturbed in this.
Definitely. So if you are experiencing these symptoms like Professor Neville Perera just explained, hesitancy, poor urinary flow, getting up in the night to void a couple of times, and maybe urge incontinence, all of those symptoms might be giving you a sign that there is something wrong with your prostate. So if you can continue to join us with this discussion, we are going to go into depth of what these problems in the prostate are. So which brings me to the question, what are these conditions which will enlarge the prostate gland?
Actually, it depends on your age, and there are 3 main diseases which can affect the prostate in 3 periods of your life. And when you are relatively young, say in your 30s and 40s, these symptoms can come due to a slight enlargement of the prostate following an infection. So that is called prostatitis. Prostatitis that affects generally the younger crowd. So that is the first time you will get disturbed by these prostate diseases. So that's fairly common, and sometimes it can be caused by a bacteria or sometimes sexually transmitted diseases. So if you are young and you are having these symptoms, not always, but it may be that your prostate gland got enlarged due to infection. The second disease is the most prevalent and most common disease, called BPH, is our, in medical terms, benign prostatic hypertrophy. That's a very tongue twisting word, but that basically means benign enlargement of the prostate. The prostate gets enlarged due to the age, and then all these symptoms will start coming up. So this benign prostatic enlargement will be starting around the age of 40, and then it will be there, it will affect the people up to about 70 years. So between 40 and 70, this is the main disease you will be affected. Then comes the more dangerous and more sinister part. When you are above 70, there is a possibility that this gland will get enlarged, due to a cancer. So cancerous changes. That doesn't mean only the people who are above 80 will get cancer. Even people with say around 45, 50 can get cancers, but the common age group you see these cancer is 60 to 70. So these three diseases can affect the prostate gland: the infection, benign enlargement, and the cancer.
Definitely. Now, like Professor Neville Perera was explaining, it might be a very sinister cause which is giving rise to your urinary symptoms. So, like I always say, if you are experiencing symptoms, don't try to self-medicate, don't neglect it, always seek the attention of a properly qualified medical practitioner. Now, you mentioned BPH, or benign prostatic hypertrophy. So, how common is it in our society? As a urological surgeon, how often do you see these patients?
Yes, I think it's quite a common disease compared to diabetes and hypertension. They have given some world figures that it is more prevalent than diabetes and hypertension. That will give how sort of common it is.
Yes.
Because it's an age-related disease. Enlargement itself will be there in about say 60 to 70% of people above the age of 40. But that doesn't mean that it is going to give trouble. So all enlarged prostates, only about 50% of these enlarged prostates will give rise to symptoms, the symptoms we described. So that is good news, because sometimes you may be carrying a large prostate, incidentally found, but there's no symptoms. So that is quite possible. And out of these 50% of people who are having symptoms, only about 50% of them will need actually treatment. And out of these 50% of people who need treatment also, the good news is that surgery will be done only for people, say, for only about 10% of people. So ultimately it will be corned down. And if you are worried about surgery and things, surgical intervention, it is corned down to about 10% of people who will undergo surgery. Most of them will be managed with medication.
So, if you are above the age of 40 and if you are having these symptoms, it might be a case of BPH or benign prostatic hypertrophy. Now, if such a patient presents to you, sir, what would be your approach in diagnosing this patient and deciding on what sort of treatment that they should be on?
Yes, I think younger you are, I think we have to exclude certain other diseases, because not only the prostatic enlargement, but there can be other diseases like narrowing down of the urethra, which we call strictures, due to infection or sometimes previous instrumentation. The water pipe might have got damaged and then got narrowed down. So that is an entirely different disease, and then also it could be just a temporary infection of the water pipe. So there are other diseases which we have to exclude. So if you are young, say around 30, 40, we won't be straight away thinking of the prostate enlargement. But between 40 and 60, it will be most likely that it is a prostatic enlargement. And if you are older, we have to think of the cancerous part also. So we will be initially examining the patient to make sure that this prostate gland is enlarged, or whether there are physical signs of cancer. So on examination, after taking a proper history of his symptoms and signs, the examination we will be doing, I think all these patients, an internal examination, what we call a per-rectal examination or rectal examination, to feel the prostate gland. The prostate gland is very close to the rectum. It is just next to the rectal wall, so that in a way it's lucky, because our finger can reach through the rectum. We can feel the prostate gland, and the feel of it, sometimes you might be able to say whether this is a benign or harmless enlargement, or whether this is a cancerous enlargement, because the consistency of it, and there are certain other features of cancer, a trained person can identify that.
So now, sir, you spoke about taking a proper history and the examination. So what are the types of investigations, let's say blood or imaging, what type of investigations would you employ to make a further confirmation of your diagnosis?
Yes, that is very important, a good important question, because as I was mentioning, through the rectum what we can feel of this prostate, which is like a lime, it's a mass of flesh, what we can feel is only part of the prostate, because only the back part of the prostate we can feel. But we mustn't forget that there's another part in front which can grow into the bladder and which we can't feel. So feeling itself is not adequate at all. So to confirm what's going on there, we routinely do a urine test to start with, to make sure that the prostate has not blocked the bladder and it has led to infection, and then some kidney function test to see whether the prostate gland block has affected the kidneys. So we do tests like serum creatinine or blood urea. And then the most important investigation will be the ultrasound scan. But nowadays, what we can't feel, where we can get the details from a good ultrasound scan. But only problem with the ultrasound scan is it depends on the person who does it and the machinery, because it's a operator dependent investigation. But the information we will get are the size of the prostate. They can tell us whether it is really enlarged or not, because we know the normal size of the prostate, and it will be given in grams. So a normal prostate will be around, say, about 20 grams when you are young, and when you are older it will move towards 40. But suppose it is 80 or 100, you know it's a fairly big gland. And then also it will show, the most important thing is how far it has blocked the bladder. So it is essential for the ultrasound specialist to ask the patient to go and empty his bladder and come back. So first, the ultrasonologist will check the bladder volume. That, let us say, about 300 cc was there. For that, the patient also should know that when they are going for the scan, they must go with a full bladder. So if it is 300 cc, he goes and passes urine and come back, and there's 200 cc still inside, milliliters inside, you know that this bladder is blocked. And also another very important information you are going to gather is whether this prostate block has affected your kidneys. Because kidneys are in the upstairs, and when the prostate is blocking your bladder, that pressure which is built up inside can get transmitted to the kidneys, and they also can get bloated up. That is a very dangerous situation, and that can be picked up by doing ultrasound scan. Always with ultrasound scan, there is another part, because we come across ultrasound scans done half-heartedly, giving some information but not all. The other half is that there is a special machine onto which, it's like a commode-like thing, onto which you have to pass urine, and then you will get a little strip like a ECG. And by studying that, we can interpret that and say how fast you are passing urine. So if studying the shape of the thing and then the figures, if we feel that your bladder is blocked, then I think that is very valuable information for us to start treatment.
So all these host of investigations put together with your clinical history and your examination, then we can pinpoint to disease of either benign prostatic hypertrophy or maybe whether it's going towards cancer of the prostate. Now, when we're talking about the prostates, even amongst the lay communities, there's this investigation called the PSA, which is even a common knowledge to our lay community. So, if you can just describe to us what PSA is and what is its significance when it comes to BPH or prostatic cancers.
Yes, good question. I think now it is becoming, as you quite correctly said, there is a very common investigation nowadays among the people over 40. In some other countries, they do routinely during health checkup, and then some of us now what we call opportunistic use of PSA, where when the patient comes with symptoms, we do PSA. So PSA stands for prostate specific antigen. So it is a protein which is excreted by the prostate gland. So it is coming only from the prostate gland. No other part of the body will secrete PSA. So when this protein is generally secreted into semen, but you don't get high levels in blood because it's a seminal protein. But in disease like infection, or when the gland is very big, or it has got converted into a cancer, this chemical or this protein get released into blood in abnormal levels. All males will have a very low level of PSA in their blood. Most of the PSA goes to the semen, seminal fluid. But in these diseases, this protein gets released into blood and the blood levels can go up. So you will, our spectators will realize that these three diseases, prostate infection, or when there is a large prostate gland, or when there is a cancer, the release of this PSA protein into blood will happen and the blood levels will go up. So PSA is very specific for the prostate gland, but it is not specific for the disease. So just because you have a high PSA, you should not start thinking of cancer. But that may be an early sign of cancer, early warning of a cancer. So we have to proceed with other investigations to exclude cancer. So it's just a blood test, and people who come with these prostate symptoms, now we invariably do a PSA.
Just for clarification purposes, now you described three conditions: the prostatitis, the BPH, and the cancers. So in all three conditions, is the PSA level elevated?
Yes. If you take the normal PSA, actually there is no hard and fast limit for PSA, but it's generally taken as 4, as a figure. It comes as a figure. For clarification, it is 4, and it can go towards 10, 20 and even hundreds. So depending on that elevation, we will be able to just suspect whether there is a cancer or not. But then you can't be 100% sure, because sometimes infection can push this figure towards 20. But suppose the figure from the beginning, if it is about 100, then there's a high chance that you may be harboring a cancer. But again, there is only a chance. So in all three conditions, the PSA is high. So only way to exclude that is to go for a biopsy if you are suspecting clinically this is a cancer.
Definitely. Now, you may be advocated to get a PSA and don't try to interpret the results by yourself, because like Professor Neville Perera said, not every high PSA indicates that you are harboring a cancer. So it is definitely pertinent that you get followed up by your urologist or your medical practitioner. Now, moving forward with our discussion of BPH. Now, let's say a patient presents to you with all these symptoms that we discussed, and you have employed these investigations and found that indeed, okay, this patient is having an enlarged prostate and probably caused by BPH. What would be the modalities of treatment available for these patients? Does it always indicate that they have to go in for surgery, or is there medical treatment options also available?
Yeah, I think fortunately nowadays the mild symptoms, when you study the symptoms, there is a way of scoring them among us. I think we can, by asking questions, we can score it, and then we can find out whether those are mild symptoms, moderate symptoms or severe symptoms. So if those are mild symptoms, nowadays, even without any kind of medication, just by having some lifestyle modifications, you can control the symptoms. Suppose you have a very early enlargement of prostate, and then your bladder is not emptying fully. That's why you are having the frequency. So if we realize that is the situation, simply asking the patient to empty the bladder twice, which is called double voiding. You pass urine and wait for 2 minutes before you come out of the toilet, and then empty the bladder again. By simply doing that, he will not have the frequency, because he will empty the bladder at the same time. But if we don't give that advice, he will pass urine, and the remaining urine, after about another half an hour, he has to run to the toilet again. So you can just prevent that. And some people with prostate irritation of the bladder and getting up in the night, the nocturia part, and sometimes they don't know that if they drink a lot of water after 5 o'clock. Some people come after work after 5 o'clock, and then they start drinking and eating and drinking everything in the evening. So they drink sometimes a large amount of water in the night, and if he has a prostate enlargement blockage, he will get up because he drinks a lot of water. By just giving a simple advice to stop drinking after 5 o'clock, because anyway, normal body doesn't need much water in the night. It is sort of made in such a way that night urine production also goes down. So by just giving simple advice to avoid water after 5 o'clock, he will be relieved. So he doesn't need any treatment, he doesn't need any medication. And again, sometimes time voiding, sometimes people wait until they are really full. So when they are really full, the people with prostate, they have to run to the toilet, otherwise they will empty then and there. So if you just tell them, go by the clock and empty the bladder every 4 hours, like meal times, like 8 o'clock, 12 o'clock, 4 o'clock, 8 o'clock, then the bladder won't get overfilled. So that symptom of running to the toilet will disappear. So that sort of a lifestyle modifications will be enough for those people. But if those are not working only, we move on to drug therapy. So if you take the drugs, of course, nowadays for last 2 decades, 80% of prostatic symptoms and prostate enlargement with symptoms are managed with drugs. There are 2 main types of drugs for this prostate gland. One group is called prostate relaxants, other group is called prostate shrinkers. The prostate relaxant, what it does is that when you take it every night, those tablets, the prostate has some muscles inside which increase its tone. So it just decreases the tone and then open up the water pipe which is compressed, which is squashed. So by giving that drug every day, you find that you can pass urine easily, your blocking symptoms have disappeared. But only thing is that those drugs have to be taken every day for a minimum period of 2 years, and some people up to about 5 to 10 years, because they act only on that particular day. And prostate shrinkers are entirely different group of drugs which will slowly shrink the prostate gland. Its glandular part and the muscles and everything will be shrunken. But again, it will start shrinking the prostate after about 6 months, and the job will be completed only after 6 years. So these drugs have to be taken in a long-term basis.
Definitely. Now, all enlarged prostates doesn't mean that you have to go in for surgeries to go under the knife. So, like Professor Neville Perera very correctly said, it was very invaluable advice for all our viewers. But of course, it has to be done with the advice of your medical practitioner. Simple lifestyle changes may relieve you of your symptoms. Even if it doesn't, there are certain drugs that can be taken to relieve your symptoms and give you a proper cure. But of course, it has to be taken as prescribed by your doctor. So, moving on with the treatments, now we spoke about surgery. For BPH, what sort of surgical options are available?
Yes, I think people, while on medication, if they fail to improve, their symptoms become worse. That happens actually if you give medication for 100 people, to 100 people, about say 20 people will fail. That is the nature of their prostate, and there is no answer to that. If they come and say that despite this medication, my symptoms are really bad, I am suffering, I can't go on like this, then of course we have to offer him surgery if symptoms goes and symptoms have become worse. And on the other hand, while on medication, they go into a block. While on both medications, they suddenly go into a block which is called acute retention of urine. If in that situation there is nothing more to give, so what you have to do is offer surgery for him. There's no point changing the drug from one name to the other. So that's the end of the story for drugs. So that is another indication, and another important indication to undergo surgery will be, because we'll be following up these patients every 6 months or 1 year with ultrasound scans to see whether the prostate is responding to these drugs. So in between, if you suddenly find that while he's on medication, he's not emptying his bladder properly, and his kidneys are getting bloated up, they are getting blocked. If you observe that, then even the patient says that I am okay, my symptoms are all right, you have to offer them surgery. Because the kidneys are getting affected, there is no place for surgery. So, no place for medication. You have to go for surgery. So, those are the strong indications for surgery. When it comes to surgery, I think people should not be sort of too worried about it, because it's very standard now, standardized all the surgery. And most of the time, I think 95% of time, there won't be any cuts from outside. All the whole surgery will be, the total procedure will be done through the water pipe itself, using a small telescopes, under most occasions under spinal anesthesia. Even sometimes some people prefer to watch the surgery also. I mean, they just look at the screen because it is in the video screen. So they watch the surgery. So they are fully awake. And then what we do is with these telescopes we have special instruments, sometimes those that uses electricity or electrocautery, or sometimes laser. So both energy sources are there. Those are just energy sources. So you can use either energy source and then cut this gland from inside into small pieces, the central part of the gland. I must tell you that this whole gland cannot be removed in this technique. It should not be removed because this benign enlargement is there in the central part. Because I told that it is like a fruit. So there's a shell and a core. So what we do is we take the core out so that blockage will be gone. So this can be done with these instruments, and you cut it into small pieces and wash it off, and then block all the blood vessels, seal off the blood vessels, and then after surgery the patient will be passing urine very freely through that cavity. So surgery means that no cuts from outside. But if you have a very large prostate, very rarely we might have to make a small cut from the lower part of the tummy and yam out the central part of it because it's very big.
So in this day and age of technology, it doesn't necessarily mean that you will have to have an open surgery for your enlarged prostate, especially when we're talking about benign prostatic hypertrophy. Like Professor Neville Perera said, it is done through telescopes passed in through your water tube. So now, sir, just for the benefit of our viewers, once they do undergo this type of surgery, what is the post-operative recovery period? Do they have to stay in the hospital for a long period? Do they have to abstain from their day-to-day routines? How does that work?
Yes, because there are no cuts involved in this surgery. Most of the people, the following day they are discharged. And the first 24 hours after surgery, they will be carrying a catheter, a tube in the bladder, which goes through the wound which is inside. And once what is coming out from there, from the catheter is clear, that generally happens after 24 hours, that will be removed, and when patient has passed urine once or twice, we discharge them. So the general hospital stay is about 2 days. And what we advise them very strongly is, because there is a wound inside which they can't see, if they exert themselves, most important advice will be not to strain. If they strain during the first 5 to 7 days, they lift heavy weights or do long walks or swimming or cycling especially, if you do anything to strain the abdomen, the tiny vessels, tiny blood vessels we have sealed off with electrocautery or laser, they opens up. Once they open up, you can have a bleeding again. So because of that, first 5 to 7 days, you don't have to rest in the bed, but you can do your normal daily routines, but not heavy work. Office work you can do, and with the slightest indication, sign of bleeding, you have to come back to the hospital.
Now, we have been discussing in depth about the benign condition, the benign prostatic hypertrophy, what sort of treatment modalities are available, what sort of symptom profile you may be facing. Now, moving on to the most sinister cause of this enlargement of prostate, sir. Now, prostate cancers, is it very common in the Sri Lankan setup?
Fortunately, all Asians, especially South Asians and even Southeast Asians, in Asia, the prostate cancer is not that prevalent for some genetic reason, most probably, compared to the West. West, it is the second most common cancer in the Western Hemisphere, and second most common cause of the death of males above the age of 50. So that is a very dangerous situation there, and very dire situation there. And in some ethnic groups like Afro-Americans, it is quite common, and the death rates are also pretty high. And also Northern Europe, it is a common disease, and to the extent of that becoming a national problem. So they have various programs to detect it early and try to reduce the number of deaths. But fortunately, that scenario is not seen in the South Asia. Maybe that our lifespan may be little lower compared to the West. Western people might live up to about 85. So if you live long enough, you can be killed by this prostate cancer. But maybe that before that age limit we are finishing our life. So that may be one reason, but more than that, what I feel is that we have some kind of a genetic protection against this prostate cancer. And unlike in the West, we don't see very many people coming and dying every day with metastatic or prostatic cancer which has spread all over the body. That doesn't happen that frequently now. I have been in this field for nearly 30 years now. So that situation is quite different. And I think we are sharing the same feeling with the other South Asian countries and Southeast Asia. But that doesn't mean that we are safe.
Definitely. Now, that's positive news for our viewers joining in from Sri Lanka and South Asian countries as well. Prostatic cancer, even though not so prevalent, like Professor Neville Perera said, it doesn't mean that it's absent. It might be there. So you need to definitely keep an eye out for this condition. Now, sir, you said there is some sort of genetic protection. Now we talk about the risk factors. What would be the risk factors for the development of prostatic cancer?
Yes, the biggest risk factor given by everybody in all the textbook is the age. If you live long enough, if you age, then of course there is a high chance of getting prostate cancer. What is said and what is found in literature is that if you live long enough, if you live up to 90%, you will die with a prostate cancer. Prostate cancer, there is a 90% chance that you will be harboring a prostate cancer, but you are not dying from it. You are dying with it. So that is the formula. So most of the time, as you grow old, so if you are older than 60, there is about 40% chance that you may be harboring a small spot of prostate cancer, but that is not going to affect your life. So that factor is very important, because as you grow old, there is a higher chance that you will be having a prostate cancer. But if you are older, there is a lesser chance that you will be dying from it. So important message is that you have to catch the cancer. If you catch a cancer at an early stage when you are younger, that needs some sort of a strong treatment, definite treatment. But if you are older, you are not applying the same treatment because you are going to continue your life with it and not going to meet your demise with that.
Definitely. Now, when we say cancer, it's a word that strikes fear into our hearts. But like Professor Neville Perera said, early detection is key. But depending on your age, of course, the treatment modalities may vary. Now, still continuing on the risk factors, and now we have heard and seen in certain literature about the risk of smoking or alcohol intake. Some say a high cholesterol diet might lead to prostatic cancers. Are these facts proven? Does it have a direct relationship with the cancers of the prostate?
Yes, there are studies to show that certain foodstuff, including lycopenes, are protective. Lycopene is what you find in tomatoes, that is protective, and in the sunlight, even sunlight is protective, because when you have a lot of melanin and then exposure to ultraviolet light, that is protective. And then some sort of sexual behaviors can predispose to prostate cancer, having multiple partners, but those were all theories, and they were not proven beyond doubt. And also as you said, cholesterol, high cholesterol diet, smoking and alcohol, those are all they have not been proven beyond doubt, because some study will say that smoking affects the man and get a cancer, but other studies will show that it is not. And alcohol, in some rare studies, will show that it is protective so against prostate cancer. So none of these things are conclusive, apart from there is a familial tendency. There are certain prostate cancers which are familial because you are inheriting that gene from your parents. So if your close relations like father, uncle, and then your brothers or twin brother, they have a cancer, you have a high chance of getting cancer. So you are inheriting that gene. So that is another risk factor, strong risk factor. But unlike, say, other cancers like bladder cancer or renal cancer or kidney cancer, smoking and alcohol doesn't have a very strong effect on prostate cancer. That doesn't mean, by no means it means
Exactly.
that, no means I'm intending
not
to say that it is
advocating.
advocating smoking or alcohol.
Definitely. Now, even though it doesn't have a proven relationship with prostate cancers, like Professor Neville Perera said, and like we say on Healthline time and time again, smoking, alcohol, or bad lifestyle will always predispose towards some sinister conditions. So, always best to take the middle path, abstain from bad lifestyle habits, have a balanced diet, and definitely avoid smoking and alcohol. Now, you spoke about these familial tendencies, the genetic predisposition. If a patient has a strong family history of prostatic carcinomas or cancers, how often should they get screened and when should they start?
Yeah, I think early screening. Now, generally we start prostatic screening after the age of 45, 40 or 45. But if you have a very strong family history, even without any symptoms, you should advise the patient to have a PSA, that is the starting point, and an ultrasound, and then to do a clinical examination to see whether he is harboring a familial prostate cancer. So you start screening them a bit early.
So even for a male without this genetic predisposition, what you're advocating is that they should get screened after the age of 45, is it?
Yes, that is kind of a yes, that's a kind of a controversy again, because in the Western countries where the disease is prevalent, after the age of 45, all health checkups will include PSA, and that is called a screening. But to have a screening program, the disease has to be prevalent. Now we screen for cervical cancer in females, uterine cervical cancer, because it's kind of a prevalent disease which is preventable if you detect it early. But prostate cancer, the same criteria will not apply. So in this part of the world, asking everybody to do after the age of 40 or 45 to do a PSA is not done. So what we do is we do opportunistic PSA, that is, if he has some symptoms and he comes to us, we grab that opportunity and do a PSA. But anybody who is concerned about his health, prostatic health, or and doing a PSA after the age of 40, I think nobody can say no.
Definitely. Now, before, when we were talking about BPH or benign prostatic hypertrophy, we spoke of a symptom profile which is associated with the enlarging prostate. Now, apart from those, are there any other symptoms and signs that might develop with prostatic cancers?
Unfortunately, Dilshan, these early symptoms of prostate cancer is very much similar to the BPH. When it is enlarging, it blocks the water pipe at one particular point, and then you get all these similar symptoms. But at the extremes of this spectrum, that is very early prostate cancer, there are no symptoms at all, because it is confined to the gland, it is inside the gland growing, but no symptoms because it is not touching the water pipe. On the other hand, the other end of the spectrum, if it is fully involving the prostate gland and it has spread outside the prostate gland, the first place it will go and get settled when it spreads outside the prostate is the bone. So you get backache. You get a backache, sometimes in one place, sometimes throughout the day you will get a backache, and then sometimes the bones get so weak and nerves get entrapped, and then you get the pain going down the legs, lower limbs, and those are the symptoms of a spread, metastatic or prostate cancer when it is spread outside the prostate. So only at these two extremes you will get different symptoms. One end, no symptoms. Other end, you get backache and sometimes you get pain in the between your legs, down there. But in between, the symptoms are similar to BPH.
Right. That is one point that we want to reiterate once again here on Healthline. The initial symptoms of prostatic cancers may mimic what we discussed with the benign prostatic hypertrophy as well. So, and even if you are experiencing these symptoms, and what we advocate is for you not to think that it is a benign condition. Of course, seek medical attention, make sure 100% do the relevant investigations and make sure that what is causing your symptoms and that is not a cancerous condition. Now, talking about cancers, now you said it's something that will spread out of the prostate and it will go and settle in bones and all that. So, we spoke about the PSA. So, a patient coming to you with a similar symptom profile with a high PSA, what specific investigations would you employ in this condition to confirm a diagnosis of cancer?
Initially, what we have to prove that there is a cancer, and as I was mentioning earlier, the early prostate cancers you can't feel. So when you do a rectal examination, even you won't feel it. It's just that the PSA levels have gone up beyond a certain limit. So by looking at the size of the prostate, we have to figure out what is that particular person's PSA is going to be. So that's why I was telling that PSA doesn't have a fixed figure. So if you have a 40-gram prostate, your PSA will be 4. If you have a 60-gram prostate, your PSA will be 6.
So it correlates with the size?
Correlates with the size. If you have a larger prostate, you have a higher PSA. But suppose you have a 20-gram prostate and your PSA is 10 or 15, that is abnormal. So when you do the rectal examination, early prostate cancers, you might not feel anything because it's inside. So if there is a suspicion, strong suspicion that PSA is high and we are dealing with a prostate cancer, we may be dealing with a prostate cancer, only way out is to take a biopsy. Biopsy is done under local anesthesia and ultrasound guided. And this is done in our part of the world, mainly done by the radiologists. And a small part of the ultrasound scan, the scanner, will be inserted into the rectum under local anesthesia. A jelly will be put in, and sometimes a local anesthetic injection will be given, a tiny needle. You don't feel much pain at all. It's done as a day case, in and out, no admission needed. And the scanner, once it enters like our finger entering the rectum, when it enters the rectum, it will show up the prostate very clearly in the screen. So the radiologist can insert a tiny needle under local anesthesia and take small pieces from the prostate from all over the place to represent the whole prostate. And then that will be sent for checking, and after about 10 days the report will come. So fortunately, out of these reports, there's a 70% chance that it will be a benign thing. It may be just infection, it may be an old infection, or it may be just a benign prostatic enlargement. But only about 30% of time you will find that there is a cancer.
Now, after this histopathology report, if it is indeed a cancer, how would we proceed with the treatment options? What are the considerations when it comes to treatment in these patients with prostatic cancers?
Yeah, important thing is that how to break the bad news. So once you have got the report that it's a cancer, that's not the end of the road. Because depending on the report, you can classify these patients into very low risk, intermediate risk and high risk groups. So we put various figures into an equation. That's why you have to be with a specialist for this, like PSA level and the type of cancer under the microscope, and the various other factors into the thing, what you feel from the finger, and putting everything together, ultimately we have to put this patient into one of these groups. So it will be either very low risk, intermediate risk or high risk. So what you have to realize is that no two patients are alike. So you have to decide to which risk category he is falling into.
So it's a very individual approach.
So if it is a very low risk group, though it is a cancer, we adapt nowadays a treatment method called active surveillance. Because good old days, about 10 years or 15 years back, all these patients were operated, or all these patients were given treatment, and there is a thing called treatment toxicity, where when you do the operation, there are various side effects, serious side effects, and radiotherapy also carries serious side effects, and we are subjecting these very low risk people to this unnecessary risk of the treatment. So these patients can be just observed, and that is kind of treatment modality nowadays. In America and in the West, this is well established treatment method which is called active surveillance. It doesn't mean do nothing. That is the most important thing. What you do is every 3 months to start with, or 6 months, we do certain tests and see whether this tiny cancer which we have picked up is growing. So at any stage, say after about 3 years, 4 years, 5 years, 6 years, if we get an indication that this cancer is starting to grow, then we give full treatment option to them. And what they have shown in studies is that even if you start it now in this group, start treating them now, or after another 10 years, when you develop the symptoms, if you give treatment, final result is going to be the same. So you have prevented that person from getting side effects of the treatment for 10 years. He has enjoyed his life. So we have to tell the patient very clearly about this situation and discuss it. So he is living with this cancer, but which might not surface for the rest of his life. You never know. So this low risk and very low risk groups, this treatment modality of active surveillance or observation is there. But clearly you must remember that this is not doing nothing.
Exactly, because some of our patients might think that, okay, I went to a specialist and they did nothing for me and I'm just living with this cancer. So this is something very important for our viewers to understand. If you're falling into the very low risk or low risk category with regards to prostatic cancer, which was decided by a consultant specialist in urology, then active surveillance or actively monitoring this cancer is accepted and proven treatment method, like Professor Neville Perera is saying. So continuing with the rest of the risk categories.
Yes, and the intermediate, then comes the intermediate group, which we know that if you leave them alone, more sooner than later, this cancer will grow and spread outside, and that will be kind of too late for this patient to cure him. So if it is intermediate risk group, or the other one is bad risk or high risk group, those two groups we have to offer them treatment, because if we don't, then there is a possibility that cancer will grow and it will spread outside, and the chances of curing this cancer is gone. So that good news hidden in that statement is that this cancer is curable.
Curable, exactly.
Curable. So unlike good old days, when we were starting our training 35 years ago, all the prostate cancers were too late, they were all spread, and then we give treatment, but there is no hope of curing them. But now, if you catch them early and then you categorize them as intermediate or high risk group, you offer treatment. And out of the two treatment modalities available for these people to get cured, number one is the surgery. As a surgeon, I will put it as number one. Yes. That is removing the whole prostate. And you must not get confused with the previous surgery we were describing, where the core of the prostate is removed for benign prostatic hyperplasia. This is removal of the whole prostate with the adjacent glands and all the lymph nodes. These are the tiny little lymph nodes which may be harboring some cells there. So we take the whole thing out. And then when you take the whole thing out, you will realize that the bladder is in one end and the water pipe is at one end. There's nothing, there's a hollow in between. So we have to bring the water pipe and attach that to the bladder. You have to do it in a meticulous way that this water pipe is controlled by the sphincters or valves there. So those have to be preserved very carefully. So that to do that surgery, you need real expertise and technology. So that is called radical prostatectomy. It's not transurethral resection we described earlier. Radical prostatectomy, where you remove the whole prostate and reconstruct the continuity of the urinary path.
So as opposed to the previous surgery, this is an open procedure?
This can be done either open or laparoscopic, with keyhole surgery laparoscopically, and most commonly done technique in the West is robotics. Robotics is just an extension of laparoscopy, where, laparoscopy is keyhole surgery, where we do the whole lot through little keyholes and watching it in the big screen. And instead of we holding the instruments, we fix it to the robot. And robot does nothing. Robot is just a slave, and he just holds the instruments, and we operate it. And sitting in the corner of the theater is relaxing for us. Actually, it's more relaxing for the surgeon rather than the patient. But you have a very good view through the robot's eyes, and then we manipulate the robot and do the same surgery as laparoscopy or open surgery. Surgical technique is not different, same thing, but keyhole surgery with the assistance of robot. That's called robotic assisted laparoscopic or robotic assisted laparoscopic radical prostatectomy.
Is this technology available in Sri Lanka, sir?
Unfortunately not. In the West it is quite common, and even in the East, like Korea has so many robots now, I think. And India was arguing for a while, sometimes back, whether to buy a robot or not. It's cost effective now, they have forgotten that, and there are many places where robotics are done. But unfortunately for our country, we were just about to buy a robot when these problems came in, the social and economical COVID problems came in. But I think it's once the things are settled, we have not given up it, and we'll sooner or later we will have the robotic facility.
Now, with the time constraints we have, sir, we are coming towards the end part of the program. But before we wind up, now we spoke about surgery for prostatic cancers. What are the other options available?
Yes, finally I think we must say that we are unfortunate to see some patients coming very late where the cancer has spread to the bones and PSA is sky high, and those patients we don't talk about cure, but we can, fortunately we can, with drug therapy we can keep them very comfortable and sometimes continue their life in the same manner. And also, if the patients are not fit for surgery, the other option is radiotherapy. And radiotherapy, what you do is you give the radiotherapy to the prostate and destroy all the cancer cells. That's a good treatment, but the problem is that sometimes if you live long enough, there is a slight possibility that the cancer might come back because you are leaving that gland there. Yes. So radiotherapy is a good option, but for older people, but younger people, I think surgery is still the best. But if the cancer is spread, what you do is you drop the hormone levels, male hormone levels, it's called testosterone. You drop the hormone levels because this cancer depends, fortunately, cancer depends on male hormone, testosterone, for its nourishment. So moment you get rid of the male hormones from your body, the cancer cells will shrink. Though we are not talking about a cure, you can get a good control of the cancer for a long period. And that can be achieved by either removing the hormone producing organ, which is the testicles. So sometimes you have to remove the part of the testicle to get rid of this male hormone. Or now there are drugs which are expensive, but they are available in the government sector. Now certain drugs to counteract the effect of the hormones. So you have to get every 3 months an injection or sometimes tablets for about 2 years to block the male hormones. So that is also possible. For the cancer which is spread, either you can remove the testicles or you can go for these drugs.
Now, our viewers might wonder, sir, when you say blocking the male hormones, are there any associated side effects with this modality?
Good question. Yes, the good thing is that however much we block, there is no 100% blockage. You can bring the hormone levels to a very low level, but hormones are also produced in the glands called adrenal glands and the fatty tissue. So those hormones can maintain the hormonal function, but for an adult you need a very minimal amount of testosterone to function. But on the other hand, there is a situation called andropause. Andropause, like menopause. The patients, when their testosterone levels are low, they go into a situation, a quick aging situation, which is called andropause, where you feel sort of weak and lethargic, and sometimes you can't concentrate. So these problems are there, and we have to be aware of that.
But considering the benefits over the risk, I believe it is a necessary intervention in these cases.
Exactly.
Now, one final question before we wind up, sir. Now, a patient who's having prostate cancer, undergone surgery or these treatment modalities, and you said there might be, if they haven't taken out the entire prostate, there might be a chance of recurrence. How often should they review, and how should they follow up?
Yes, after the radical prostatectomy, after removing the prostate, for first year, we check them every 3 months or so, because sometimes they can have some side effects like incontinence. That is, the urine control might take time to come, because we are bringing the valves and water pipe and attaching it to the bladder. So sometimes what happens, however skillfully we do that, Sometimes some patients up to about first 1 year, they find it when they cough and sneeze, they leak. So that is a problem. We have to explain them beforehand. And also their sexual functions, erections can go down. So those two side effects are there. So because of that, every 3 months we check them to see with a PSA to see whether there is any kind of a rising there. And then after the first year, if they are settled, then once in 6 months for another year or so, and then yearly for about 10 years we have to see them.
Right. So, with the time constraints, we are coming towards the end of this edition of Healthline. We discussed in depth about the conditions that affect the prostate glands in the males. I'm sure all of our viewers benefited greatly from the expert opinions from our guest today, Professor Neville Perera. Thank you very much, sir, for gracing the Healthline studios once again, for educating our public on this very common condition. Thank you for joining us this evening.
Thank you, Dilshan, for inviting me for this quite useful health discussion.
Right. With that, we wind up this edition of Healthline. Until we meet you again next week with your weekly dose of wellness, I'm Dr. Dilshan Fernando, wishing all our viewers Ayubowan.